Hello, everyone. My name is Yeeun Kim, and I would like to talk about the IP barrier and how patent laws threaten AI-driven global health innovation. Starting off with a little bit about myself, I'm a rising senior at Kijeon Girls High School located in Jeonju, South Korea. Some of my extracurriculars are the Experimental Science Club, Red Cross Youth, and mentoring for consecutive and SLE Jeonju cohorts. My hobbies are producing music and vocal engineering, and I'm also a short track skater and varsity track runner. My goal is to go into biotech equity, and I'm planning to undergrad in biology and/or finance. Let me start with a stark illustration of our current crisis. During COVID-19, wealthy countries pre-ordered 6 billion vaccine doses, while less than 1% initially reached developing countries. And this resulted in 82% vaccination rates in high-income countries versus just 23% in low-income countries. This wasn't about manufacturing. It was about patent-protected access barriers. But COVID was just the latest chapter in an ongoing crisis affecting 2 billion people who lack access to essential medicines. Every year, thousands of Americans face life-threatening insulin rationing due to patent-protected pricing. Globally, 2.4 million people die annually from HIV and AIDS, tuberculosis, and malaria, diseases we know how to treat. Why is this happening? One major reason is that patent systems are blocking access to life-saving innovations, with 40% of health spending in low-income countries coming out of pocket. Here's what makes this crisis urgent now. Artificial intelligence is revolutionizing medicine. AI accelerates drug discovery timelines significantly instead of the traditional 15 years, but we're applying the same broken 20-year patent system to AI-generated innovations. We're at a crossroads. We either fix these systems now or amplify this crisis exponentially. My research reveals 4 critical findings. First, current patent barriers are already killing millions. Look at these specific examples. Sofosbuvir for hepatitis C costs $84,000 but has a production cost of just $68 to $136, which is a 600 times markup. Insulin costs dropped 70% in 2023, but still exceed production costs by 10 to 30 times. Trastuzumab for breast cancer costs $35,000 per year in Africa versus $100 to $200 to produce. These aren't isolated cases. They represent systematic delays or failures. Second, AI specifically amplifies this problem in unprecedented ways. Here's the paradox. AI systems train on publicly funded data, which are medical research, clinical trials, and genomic databases, but produce privately owned outputs. AI healthcare patent fillings doubled yearly from 2015 to 2021. Over 10,000 AI healthcare patents now restrict basic diagnostic tools. Google has filed patents on well-known AI techniques, creating barriers around fundamental medical AI applications with 20-year patent terms for rapidly evolving AI technologies. Third, we're seeing a critical speed mismatch. This chart shows AI drug discovery markets exploding to over $13 billion by 2032. China holds 70% of global AI patent applications. The top 10 drugs average 74 patents each, creating impenetrable patent thickets. AI companies are filing patents with minimal real-world testing, while geographic concentration systematically excludes developing countries. Last but not least, traditional solutions cannot keep up with AI's pace. Compulsory licensing takes 2 or 3 years on average, though this can be reduced to 3 to 6 months in emergencies. Drug approval delays in poor countries at 4.75 years beyond high-income country timelines. When AI can accelerate discovery significantly, these delays become critical bottlenecks. Traditional patent opposition processes averaging 1.5 years are inadequate for rapidly evolving AI-generated patents. Given these systematic failures, what would actually work? My research identified 3 key principles for effective reform. First, we need differentiated approaches based on public health impact. Not all medical innovations should receive the same patent protection. Second, we need automated classification systems to eliminate the political delays that currently plague compulsory licensing. And third, we must build equity mechanisms directly into the patent system rather than treating global access as an afterthought. This led me to come up with a framework called the Open Biodesigning Licensing System, shortened to OBLIS. Every AI-generated medical innovation gets automatically scored across 5 criteria. Public funding ratio accounts for 30%. If taxpayers funded the research, they should benefit from affordable access. Public health importance weighs 25%, technical replicability is 20%, national strategic value adds 15%, and international cooperation needs contribute 10%. Based on these scores, innovations are automatically assigned to different licensing tiers with varying levels of patent protection and access requirements. OBLIS directly tackles each problem I've identified. The speed problem gets solved through automatic classification, no more 2 to 3 year delays for compulsory licensing and decisions. The public funding paradox gets addressed through funding-based tier assignments. Public money means public benefit. The global access crisis gets built-in solutions through mandatory least developed country provisions and emergency override mechanisms. The critical finding is this: patent systems will become the biggest barrier to AI-enabled global health progress. Current systems systematically exclude 2 billion people from medical innovations. AI amplifies these problems exponentially, while traditional solutions are too slow. We have a narrow window to act before AI transforms medicine under broken patent systems. Consider the stakes. The next pandemic combined with AI discoveries could create a crisis that makes COVID vaccine inequity look minor. We have the technology to eliminate health inequity. The question is, do we all have the will to eliminate the barriers? These are my references. I'd like to thank the fellows that helped me with data resources and feedback on OBLIS, the community of health experts that sparked my interest for global health, the GHLC at JHU for giving me this great opportunity to share my thoughts, and lastly, the listeners. Thank you for spending the time to learn more about patents and equity in the global health field. If you have any questions, feel free to reach out via email. Thank you.